Samaresh was with me at the ACRS this year, and I had a similar course at the ACRS. And luckily, he contributed and he agreed to show the same presentation which he showed last week in the US. Thanks, Samaresh. I'll go to the other hall and come back.
Yeah. Thanks a lot, Dr. Kumar, and thanks for inviting me for this course. It's really nice to see a full or nearly full hall, on the first day. So I'm going to be discussing a couple of these cases, and unlike traumas and dislocations, every approach has its own value, and every case needs a different approach. So it's not like one size will fit all and one method will work for every particular case. So I'm going to show you a case of a 54-year-old who had come to our clinic a few years back with a traumatic cataract and a traumatic mydriasis. And we had done double aniridia ring segment and a hydrophobic lens in the bag at that point in time. And he complained. He came to us 5 years after the primary surgery with a whole capsular bag with the hydrophobic lens and two aniridia rings dislocated. So this is just to give you a perspective. This is how it looks. That's the aniridia ring segments that you can see, the black ones there. There's a fibrosed capsule, and that's the ring of the aniridia segments. And this is how it looks on a slate attachment. It's sinking down because of the weight, principally because, first of all, traumatic loss of zonules, and secondly, it's a really heavy bag, so it's weighing down and it's falling down. So there are a few options over here. One, we can explant the entire thing en masse and do a suture fixation or a scleral fixation. We could try and fixate the same bag, because removing this capsular bag complex involves an 8 millimeter, nearly half the cornea needs to be cut open to take out this large thing from the eye. You can do retrofixation, or you can do an intrascleral fixation, or you can just refer it off because you did good primary job and that was the end of it all. So this is just to show you how the whole thing is so wobbly. It's not like a focal zonular loss. We decided at this point in time to dissect out the capsular bag. Just sorry about this. We decided at this point in time that it was worth at this point to try and dissect out the capsular bag as the primary goal and see if we can fixate this bag complex only. Now, the good thing about PMMA, because these aniridia segments are PMMA, is there are not very strong dense adhesions between the capsule and PMMA ever. So if you put a counter traction with one forceps, we have a DMAC forceps in one hand, and using a bent 26 gauge needle, you can easily dissect out a certain area between the between the anterior capsule and the aniridia rings. Had it been only the lens, it would have been really difficult. The only catch is you don't want to let the whole thing fall posterior. So the left hand, which is stabilizing it, is not only grasping the anterior capsule, but is also keeping it anteriorly or pulling it towards the corneal endothelium to make sure the bag is stable. Once we dissected out enough space, we decided to use Ahmed segments, because Ahmed segments are small and can be slipped inside the capsular bag. And the fixation choice suture over here for us was Gore-Tex. Gore-Tex is an off-label use because it's normally used for stitching periosteum and pericardium. We now don't use this railroading technique anymore. We just snip off the Gore-Tex needles and we use DMAC forceps to pull out the threads. But just like any other scleral fixation, they can be threaded out using railroading technique. My choice of fixation, the distance from the limbus is about 2 millimeter, because it's right at the junction of the pars plana, pars pliccata, and that's where it irritates the uveal body the least, the iris the least. So once we take out the distal and then the proximal suture ends, it's important to try good knots and bury these knots properly, because it's these Gore-Tex knots that can cause granulomas at the later end. And because we already had scleral flaps in place, chances of it happening were lower. This is how the patient looks post-operatively, and this is to show you how a patient looks at post-op 1 week. You can make out both the Ahmed segment, the attachments, which are well centered, and at 1 month it looks even more well centered than before, probably due to fibrosis at one end pulling it aside. So we were able to manage this case by not opening the entire eye, because that would involve taking 6 to 8 sutures on the cornea, irregular astigmatism, and other complications of scleral fixation. And this was, in our hands, fairly good outcome in an eye which was in many ways had handled 2 or 3 traumas. Now, this is another case of a patient who had a toric IOL, and it came to us with an anteriorly dislocated lens, and also there were adhesions with the iris at this end. Now, this is a patient, it's a hydrophobic lens which is in the capsular bag, and the capsular bag only has pulled anteriorly. Now, these hydrophobic lenses cannot be refixated. It's not a great idea, because even if you try to do some sort of lasso fixation, it may not stay there, and because the capsule will eventually fibrose, these lenses may twist, giving rise to a coma or an irregular aberration. So my primary aim was to take out this lens. Also, when we are going to fixate the lens, when you're sitting temporarily, it's a good idea to fixate it superior inferior, because it's, dexterity point of view, it's easy. And it's important to be thorough in your markings, because you want to have your entry points and exit points at the same point, so that when you put a when you so for this case, I think I'm doing a intrascleral fixation. You're using a Yamane technique. You want to have the lens well centered. Made a partial thickness opening to take out this IOL. And before I take out the IOL, it's important to have my retina colleague do a proper 3-port power spanner vitrectomy to remove as much of vitreous as possible and clear off. Now you notice this patient does have a retinitis pigmentosa, so the visual outcome is guarded though. Once the vitrectomy is complete and the IOL is free of any adhesions, posteriorly we use dispersive viscoelastic, and it's extremely important when you're explanting a lens to use good dispersive viscoelastics, because nothing else will protect the endothelium. No HPMC and no cohesive viscoelastic will give that much of traction and that much of negative charge to hold on to the endothelium. Make a small entry. Again, if you notice, there's more dispersive being injected. It's being targeted upwards towards the corneal endothelium. Whatever little bit adhesions are there, sometimes it's very good to use micro forceps, micro scissors. And a lot of retina colleagues will have very good scissors, and they can be borrowed, particularly for snipping out, because if you try pull out this lens and the iris comes out, it's going to cause more damage. Once the entire IOL is free, I decided to pull out the entire IOL en masse, rather than cutting it and trying to cause more damage in the eye. But one could use a snare or maybe a IOL cutting scissors. My choice of implant was a 3-piece lens. Now this is a different company. It's a Freedom lens, because the haptics are PVDF. They're unlike the Acrosoft lenses, because the haptics don't lose memory. Because I'm planning a Yamane fixation, it's very important that the haptics are pliable, so that when you externalize them, they do not bend or turn or lose memory, because it becomes very difficult to fixate these lenses. So once I've injected the IOL into the sulcus space, note the leading haptic is inside the ciliary sulcus. I will now use. Let me just move forward in the interest of time. Once I create a little space underneath the iris, because I'm going to do underneath the iris fixation, we use these 30 gauge needles, the one that you have on the left, from another company called, I think it's TVK needles, because they have a very snug fit of this haptic into the needle. And unlike the, these are again not available, so they can be ordered from eBay from the US. And because they're very snug, and the entry point is very minimal. Notice how when the haptic comes out, it doesn't lose its memory. We've melted the haptic using thermal cautery. And same way, we are going to externalize the haptic at the other end. Again, 2 millimeters behind the limbus and not very close to the limbus, because if it's too close to the limbus, it's going to rub against the posterior surface of the iris. We studied and published this using our own modification of Miyake Apple view to see what happens posterior to the iris. Now, once the haptic has been externalized, like I said, you can use electrocautery or heat thermal cautery to melt out just a right size of the haptic, so as to cause a small bulb to form on the tip. This bulb is unlikely to go down if the IOL does rotate. Again, very important to visualize and make sure you do a thorough vitrectomy and make sure no remnant is left behind. Do I have another 5 minutes, Samita? Would you know? So I think it's okay. We'll like to conclude saying that when it comes to dislocations, and we are surprisingly seeing more and more dislocations of IOLs and IOL back complexes over the years. So it essentially would mean that nothing is permanent, and even with a good, well done phaco of our, in our clinic, we'll see our senior colleagues, good phacos, come down with us with dislocated lenses, and more of us will have to start, fixating these lenses back or explanting and putting other lenses. So forums like these and ICs like this will have more value as the years pass by, because it's surprising that it's going to turn into an epidemic sooner or later. Thank you.